Good afternoon, everyone. I'm Josh Claypo from the South Central Public Health Training Center, and welcome to today's broadcast. Today we're going to talk about cultural diversity issues and how those issues relate to health disparities. And we're going to focus specifically on the role of the public health community in these issues, and then talk about potential health policy solutions and health policy dilemmas. And to do all of this with us today, we are fortunate to have Dr. Lisa Gary. Dr. Gary is an assistant professor in the Department of Healthcare Organization and Policy at the UAB School of Public Health, and her research focuses on the experiences of vulnerable populations within the U.S. healthcare system. As with all of the broadcasts, you have an opportunity today to speak directly to Dr. Gary. Lisa. Throughout the program, you'll see our 800 number and the email address up on the screen, and you can call or email any questions or comments you may have, and we'll answer them as we receive them. The broadcast today is produced by the South Central Center in collaboration with the Alabama Department of Public Health, and funding for the center comes from the Health Resources and Services Administration. If you'd like more information about the center, you can visit the webpage. You can also still register for our program, and you can receive the handouts and the evaluation forms from the ADPH website. All right, let's get started. Lisa, I'm introducing you as this guest, but we are friends, colleagues, and work down the hall from each other. We're so excited to have you here. We've got 90 minutes to cover all kinds of stuff, but maybe just start our viewers off with, some major objectives of what they're going to get out of the 90 minutes today.
Okay, what I'm hoping we can achieve in this hour and a half is to really familiarize the public health community, public health professionals with some key ideas and concepts about race, definitions of race, culture, what we mean by diversity, then also expose them to some of the issues around health disparities for particular population groups, primarily racial minorities, such as African Americans, Latinos, and Asian Americans, as well as look at some gender differences too for health disparities for men and women. And then finally, I'd like to wrap up and spend a little bit of time talking about action items for public health community from more of a policy perspective, and trying to orient people to the policy process.
Let's start with definitions, because they're terms that we hear, all the time at the workplace, in the media, etc. And I think many of us don't understand really what we're talking about when we're talking about terms like diversity, race, disparities. So maybe if you start us there with something like diversity.
Okay. Basically, diversity really refers to relationships between different population groups and things that make us different. And oftentimes they're reflective of different power dynamics in society. There are lots of different things that we may focus in on that make us different. So things like your race, your gender, your religion even, where you live, the part of the country that you grew up in, things that are really tied to your identity of self. Those are things that help to clarify what we mean by identity groups, and kind of thinking about those various types of identity groups is what we mean by diversity.
Let's go to race, because, again, a lot of the topics that we're going to talk about today are hot topics. They're topics that make people uncomfortable, that people don't know what to say, and they don't have the right definition. So let's go through them. What about race? When we're talking about race, what does that mean?
Race is a very interesting concept because really in a lot of ways it's a social construction. It's the idea of race is something that changes over time. It varies from different population groups, from various nations, different countries. But in terms of an actual definition of race, sorry to go to this slide, but I have to. Race is basically a way of categorizing different population groups based on physical appearance.
Okay.
So people might say, race really is about black, white, ways of kind of characterizing people based on physical appearance. But really there is no clear-cut definition in terms of genotypes that really separate out different race groups, which is very interesting.
Well, yeah, it is. And you made a comment just a minute ago about that it changes. Something about race, the definition of race changes over time. Is that what you were saying?
Right.
Well, in what way?
So basically at different points of time, say in the United States, we have had different notions for what constitutes white in different racial categories. So say during slavery or just post-slavery, we had whites, we had what was called mulattoes, which were people that were of mixed race, and then you had Asian nationals, and then other Oriental was a term that was often used. So these types of concepts change over time, and they change as kind of the political landscape of wherever you are are changes.
How does that differ then from ethnicity?
Okay, so that's an interesting question. Race is, again, something that has more to do with physical appearance, whereas ethnicity taps into ideas around culture and things that help to describe how people relate to one another, their shared values and norms that they have. So, for instance, in the United States, race groups that we have that are traditionally recognized are whites as a race, and that's people who are of European descent and also of Middle Eastern descent. These are the federal categories from Office of Management and Budget. And then also we have the, quote, black race group, which is characterized as descendants of all African peoples of the African continent. And then you have the Asian population, or the Asian race, which refers to people from the Indian subcontinent as well as other parts of Asia. And then we have the Pacific Islander, which encompasses native people who are native Hawaiians as well as people from other Pacific islands like Samoa and those types of things. And so those are kind of racial categories. And then when we talk about ethnicity, the recognized ethnic groups in the U.S. are, again, according to the federal government, are Hispanic, basically. It's the only ethnicity that really is recognized. So it's Hispanic versus not Hispanic as an ethnic group. And ethnicity, again, really refers to cultural ties. So that's kind of the difference, where race kind of is more about physical appearance and ethnicity really is much more so about culture.
Well, where would, and there's all kinds of different combinations, but you talked about Hispanic, according to the federal government, ethnicity, Hispanic or non-Hispanic. So where would someone who's Latino or Hispanic fit in a racial category?
That's interesting. So within the ethnic group of Hispanic, there are people of various racial groups. So if you take people who are Cuban, there was a large African settlement in Cuba, during slavery, and so there are many Cubans who are Latino or Hispanic in their ethnicity, but they have a black race. They present as they phenotypically look like a black person, whereas there's some that look more white. And again, or even in other parts of Latin America, for example, in Venezuela, where there are large kind of groups of East Indians as well as Chinese immigrants in that country, there are people who have an Asian race, but ethnically and culturally they're Hispanic. So they may eat Hispanic foods or Latino foods, and that kind of is their cultural context, but their race may be black or white or even Asian in some instances.
Okay, so if we're talking about, well, I'm going to ask you to define health disparities too, but I want to make sure we're sort of on the same wavelength.
Okay.
When we're talking about health disparities, which you're going to talk to us about in a minute, is it important that we look at disparities among ethnic groups, racial groups, both? I mean, we talk about gender differences, but are we focusing in a particular area when we're talking about health disparities among a particular group?
That's an interesting question. I think in thinking about health disparities, it's important to think about racial differences in health outcomes, because certainly in this country, different racial groups have different experiences that may impact how they react in the healthcare system, and also their experiences in other types of social institutions. But I do think it also is important to consider ethnicity, because ethnicity gets, again, at that cultural piece, which really impacts things like your worldview, how you relate to the world, how you even perceive problems, how your ways of making sense of problems. Those types of things really speak to culture, which could again impact your health outcomes. So you want to look at disparities, I would think, from multiple perspectives, looking at disparities in health outcomes and healthcare experiences for racial groups as well as ethnic minorities. And that really gets at another issue of kind of what are some of the limits of thinking about race. And really there are many issues with race. The fact that there is no well-defined definition of what is a specific race group. It's something that's socially socially constructed. So if we were in, say, Brazil, I might be considered white, even though here I look like a black person, but there I might be considered white because their construct of race is tied more to economics and class. So because I'm someone who is well educated, has a pretty good job, by most accounts, you know, I would be considered white because that's what white is in Brazil.
And you would be labeled as such?
Yes.
Oh, interesting.
Yeah, so there's this overlay. And then, too, in Brazil, they also have, you know, the mulatto class, which we've kind of gotten rid of that designation in this country, but kind of getting at people who are of mixed race. And we see that also in South Africa. So depending on the country and kind of how things have evolved, different racial categories emerge. So again, like in South Africa, they have Africans, so people who are maybe Zulu or Xhosa from those tribes, and then they might have people that are colored who are of mixed race, and then whites, and then within whites they'll have Afrikaners versus English people or you know, European, South African. So it's very interesting depending on where you are, what those differences are. And even in this country, in places like in Washington, D.C. area where there's a lot of diversity, we have a lot of African Americans, people who are of U.S.-born slave descent, descendants of U.S. slaves, but we also have large numbers of African immigrants and Afro-Caribbeans. Those types of, all those differences play out. So in that part of the U.S., people are more prone to kind of describe themselves maybe as African American or I'm Nigerian American, whereas maybe in southern states that isn't so much the norm. Right. So most of the blacks in the southern states tend to be descendants of U.S. slaves, so they just might say they're African American or that they're black, and not really refer to their country of origin.
All right. So one more question along those lines, because we could spend 90 minutes talking about this. You said someone who would describe himself as Nigerian American, and I was thinking about the ethnic differences in culture and how that might play a difference. Is Nigerian American someone's ethnic identity, if they refer to themselves as Nigerian American,
right?
Or is that race?
That's an interesting question. So,
or does it matter? I mean,
I think it very much does matter. I think it very much does matter. Someone who would say maybe that they're Nigerian American, I think they'd be really referring to cultural context, which lends itself to ethnicity. So they're trying to define themselves in terms of this is my country of origin. I'm an American, but I have very strong cultural ties to Nigeria. And so there might be some differences with that. That person might be a first generation Nigerian American or a second generation Nigerian American, which someone would argue if they were born in the U.S., then they really are African American. Right? Okay. But their parents are from Nigeria. And so this idea of ethnicity, again, and getting back to that, and culture, let's think a little bit more about culture. What does it encompass? It encompasses things like your cultural choices, so the language that you speak, the food that you eat, your dress, your religious views. It also encompasses things like what we call collectivity, cultural collectivity, so your ways of relating to one another, whether or not you have formal or informal ways of relating to one another in different groups, your worldview, the way you interpret the world, how you identify problems, how you problem solve and think about things, also things that you do in terms of child rearing, those types of things. And then also culture encompasses things like the cultural arts, so the architecture, the design, how you see art, the music, the dance, all of those things are characteristics of one's culture that might be unique to someone who maybe is Nigerian American versus someone who's African American like me, where my cultural ties are very much from the southern states, descendants of U.S. slaves. So I might have cultural norms and beliefs that are very much tied to the experience of people who've been in this country for several generations, who are descendants of slaves, who have different orientations towards race, towards racism, towards experiences of discrimination, which someone who is an immigrant may not have. Okay, so how do we interface that with this topic of health disparities? I mean, again, maybe you go ahead, define for us what health disparities is, but now I'm really confused in terms of when we're looking at disparities,
who are we looking at and in what way are we classifying them? But maybe start with what do we mean? We're talking about health disparities.
What do you mean by health disparities? Okay, health disparities, it's a very interesting concept because actually it's interesting for a variety of reasons. The first is that in the U.S., we've kind of come up with this construct of disparities to describe differences in health outcomes. And so it's very descriptive in nature. If you say disparities, it's just that we see a difference. But there isn't necessarily a moral component to that where because we're seeing these differences that isn't a good thing. As compared to other parts of the world, say in European countries where they have these same disparities, they're labeled health inequities, where there's this value judgment to that and kind of a moral component saying that because we see differences in health outcomes and healthcare experiences by race or by gender, that's not a good thing. There's an implicit value judgment in saying health inequities, as opposed to here we just say healthcare differences or health outcomes differences. And disparities really can mean multiple things. It can describe large differences between, say, whites, the majority population, to other racial and ethnic groups. Disparities could also refer to within a particular group. Say within Latinos, are there disparities in health outcomes? So are the experiences of Puerto Ricans who have tended to be in this country much longer than say Puerto Ricans and Cubans and say newer immigrant groups, maybe from some smaller Central American countries, not Mexico but other countries, do they have different health care experiences and different health outcomes? So you can look at disparities in multiple contexts. You can look at it comparing across groups, but then also within groups, and look at a range of health outcomes. And I think since I'm in the Department of Healthcare Organization and Policy, it's important to not just think in terms of differences in health outcomes, but also differences in healthcare experiences.
Right, which again goes back to what you said earlier about the role of sort of ethnicity or cultural experiences, et cetera. All right, well, so how, so where is the research then? Where are the, when we're studying disparities, again, we hear about differences between African Americans and whites in disparities, but even just as you just described, you can drill down pretty far within African American to look at other factors. So give us kind of a primer on the research there.
Well, I think before I move on to that, let's take a step back again, thinking about these definitions and the fact that what we mean by race and by someone being black versus African American. And it's really interesting when we look at the research on health disparities and looking at differences in rates. Some of the issues that we have is just that we don't have data on these different population groups. So what is the black population? What does it encompass? What is the Asian population? Who does that cover? And what does that comprise? And are we using kind of claims data or kind of, information from administrative healthcare databases, or whether or not we're using surveys of different population groups. And if you use surveys, then you get into issues of self-report. Right. So someone can have one view of themselves and have a racial identity that they express, and I may see myself as African American or black. Well, maybe I'm not a good example, but maybe someone who it's less clear, quote, what they are, say maybe someone who's of mixed race, whether or not they mark themselves as black, and then in the survey they have bad health outcomes, we don't know, are we really describing the experiences of most blacks in America, or are we really describing the experiences of multiracials? So kind of understanding the complexities of measuring race, I think, too, is something that we need to think about and kind of self-report versus how you're perceived by other people, which gets us to, I have a couple of slides, and I guess it's on the screen, looking at
differences
in preferred racial terms. So you can have, say, for example, in the case of American Indians, they prefer, 49.8% of them prefer to be called American Indian as opposed to Alaskan Native. 37% prefer the term Native American. And if you think about Hispanics, 57.9% of them prefer to be called Hispanic versus 11.7% who refer to themselves as Latino. So you can see when you're asking these questions, you say in a doctor's office or on a survey, and you're trying to characterize different population groups, you need to be careful with what you're calling people, because if you're calling, Latino, but they don't see themselves as Latino, or they see themselves maybe as Dominican, they refer to their country of origin, they may not mark that, they may mark other, so you're not getting real information.
Well, and you even just said, going back, and I'm trying to track with you, particularly with Latino or Hispanic, you talked about that as as far as the federal government, an ethnic.
Right.
So, but that within that, there can be varying racial.
Right.
But I have seen on a number of surveys, you know, just from the research, it all kind of gets the difference between racial and ethnicity on the surveys. I mean, it's not uncommon to see Black, African American, Caucasian, Asian, Hispanic,
right,
and what else? The Pacific Islander and other.
Right.
And so what you're saying is really depending on how you make that survey up, you may get very different data.
You may get very different data, and also I think what I'm trying to, I guess, get across is that we have to be aware of different people's self-perceptions too, and what you'll be capturing in some of these survey questions. If someone, you know, doesn't see themselves reflected in those categories, that's a real missed opportunity to get information on health outcomes and healthcare experiences.
Well, okay, you decide where we go on this. I guess
okay.
I'm a little bit. Well, one part of me wants to ask you the question. You know, there's so many definitions already, and we're only in the first 20 minutes of the broadcast. And I know that myself and a lot of us are thinking, okay, when we're interacting with people of different ethnic origins and different racial origins, we want to be polite. We don't want to offend people. We don't want to be offended, etc. Right. But, you know, if you take all the definitions you just said,
right.
Frankly, I don't know what to call myself or you
right.
or anybody else. So I guess maybe just give me your thoughts on this is an issue as far as, from a public health standpoint, being able to interact. Mm-hmm. How correct does one have to be, or you know, how can public health practitioners do this in a way so that they don't inadvertently offend people or miscategorize them?
Right. I think what you're getting at is kind of, with all these different terms and all these different categories, how do public health practitioners really make sense of these categories and these cultural kind of differences and racial differences? And I think part of it is kind of moving outside of just thinking of people in terms of racial and ethnic groups and really moving towards a broader perspective of the individual. So, as you know, you're a psychologist. People have multiple identities, sure. right? And so you have a racial identity, but you also may have a class identity. Mm-hmm. You may have an identity tied to where you grew up, if you have strong Southern roots, or if you see yourself as a New Yorker, or right. a Northeasterner, or, you know, a California person,
right.
those types of things. And so really thinking about an individual in terms of their multiple identities and how that plays out, and how all of those multiple identities and cultural experiences and contexts impact how they interact with the healthcare system, and also impacts the types of resources that are available to them, and how it impacts the risk factors, potential risk factors for, you know, negative health outcomes. So it's really kind of, I think, how you make sense of this is, it's not so much what's the right term for a particular group, it's more so how do we make sense of race as an idea and think about race intersecting with other types of things like socioeconomic status, income, education, and how those different interactions impact the health outcomes of different people.
So then how do we interpret studies? Again, you know, you look at some of the larger studies looking at disparities and looking at what are categorized as African American mm-hmm. versus Caucasian. But from what you've just said, now I'm concerned about how do I even interpret those kinds of findings that, you know, we read about, we see in the media. What are we to make of those? Given what the definition that you just sort of put out in terms of how we should look at people as individuals, how do we make sense of the disparity research and findings?
I think you make sense of the research by thinking about what are potential mechanisms for why we're seeing these disparities, which kind of, I mean, it seems circular, but it is important to get back to. So say you see a report looking at for example, health disparities with respect to HIV/AIDS in the black community, and that it's one of the leading causes of death for African Americans in the younger age groups. What might be driving those types of things? Is it socioeconomic differences? Is it kind of limited resources, not having good healthcare access or access to STD testing or to health education and health behavior types of programs? And so I think making sense of the data from a public health perspective means kind of stepping back and looking at potential mechanisms. So I can spend a little time kind of talking about, for each population group, spending a little time talking about particular cultural context for each group, and then what are some of the particular disparities that are being faced by different groups.
Well, yeah, would you do that? And as we go through, I find myself wanting to say the sort of the statistical controlling for, controlling for, and so I apologize if I ask you that, but as we're going through the studies, or as we're going through some of the findings, have these disparities been found controlling for factors like education level, and which gets at what you were saying is what is driving this? Is it race? Is it ethnicity? Is it sociodemographic? Is it a little bit of everything?
Right, and I think it is. I think it is. So just kind of briefly, and I had mentioned it before about the cultural context of African Americans, and trying to get people to recognize, too, that the African American population, which is very broad, and how we think about them, really encompasses multiple groups. So it includes, like I said, people who are of descendants of U.S. slaves. It includes people who are of Afro-Caribbean descent, and those groups tend to settle in New York area, in Miami, Fort Lauderdale, Boston, and then the African immigrant groups, which tend to settle in Atlanta, Washington, D.C., those types of cities. So those are kind of trying to get at the fact that the African American population group is diverse with respect to country of origin, culture, religion. Obviously, in the African continent, there are several countries that have very large Muslim communities. So many African immigrants that immigrate here have Islam as their primary religion, which is very different, say, from most Southern blacks or African Americans who are of Southern descent who may be Christian in their orientation. So thinking about those types of things, as an example, how religion may impact how you interface with the healthcare system. Things like reproductive health care for women, African immigrant women who may have they may be more modest in how they relate to a doctor for those types of things, say, compared to people who have been here for several generations. Just one example. So there's diversity within the African American community in that context in terms of country of origin. Then there also is diversity with respect to socioeconomic status, in that Afro-Caribbeans and African immigrants tend to be of higher socioeconomic status, have more years of education than traditional African Americans do. And then also in the context of overall African American population, all groups, black women tend to be more likely to have a bachelor's degree than their men. And so what are some of the implications of those demographic differences? And one of them, which I alluded to, is the high rates of HIV in the black community, which is a major health disparity, a major issue in the black community. And I think some of in kind of trying to think about the intersections between race and, say, income and education, if you look at the fact that we have more highly educated black women, but we don't have male counterparts, then if a black woman, say, wants to continue to partner with black men, she may do so with someone who's lower SES, or maybe who has had different types of life experiences where they've engaged in practices that make them more at risk for HIV. So that increases the risk for well-educated black women or middle-aged black women to get HIV/AIDS in comparison to their white counterparts who may be just as well educated, but because they have more counterparts, more white male counterparts, their risk isn't increased because they're not partnering with people who are lower SES. So you can kind of see how, if you step back and look at race and how it intersects with other types of issues, how then you can create health disparities, or how health disparities can come about. So public health, in terms of interventions, it may not always just be focused on health behavior and health education, but it may be things like employment and kind of having more of this idea of an ecologic model of healthcare where you realize that health is impacted by multiple things. as an example. And we also know in terms of disparities, too, for African Americans that they have higher infant mortality rates than whites, and also that African Americans in general have higher death rates than whites.
Okay, so stop there on just that one, okay? Because the way you were what you were describing just previous to that statement really highlighted, as you said, the complexity of all this. But again, sort of the headlines that people read or that see is exactly what you said. African Americans have higher death rates and higher infant mortality.
Right.
But take those two examples. Can you sort of drill down a little bit? That's on average, taking into account everything that you just said from education levels, et cetera, or how does the African American group in those kinds of studies with higher mortality or infant mortality, how does it sort of break out into subgroups so that the perception is not, yes, if it's African American, there's a higher mortality rate. What you're saying is there is overall,
right,
but that overall is a pretty diverse group.
Right. And I think what's interesting is, you're right, that overall is a very diverse group, but what makes health disparities a very kind of important public health problem is the fact that even when we control for things like being higher income, having a better education, we still see the disparities if you compare, say, African Americans to whites. So even if you look at blacks and whites that are at, the same level economically, or say same education, there still is a major disparity, say in things like infant mortality.
Okay.
So college-educated women still have higher infant mortality rates than their white counterparts.
Controlling for those other factors.
Right.
Okay.
Yeah, so if you're looking at kind of, oops, sorry.
That's okay.
It dropped. If you're looking at kind of within a group, within an educational group or within an economic group, you still are going to see differences between blacks and whites. And again, what's making this interesting as a public health problem, too, is in light of the fact that we have a first-class healthcare system in the United States, we have all of this great advanced healthcare technology, we still see these disparities. And you still see these disparities even when you look at people that have similar levels of health insurance. So in a very famous study that was in New England Journal of Medicine by Schulman et al. In 2001, they saw that among Medicare enrollees, there still were significant racial disparities. So if you're taking away, you're taking away the insurance problem, okay, you're saying people, they have insurance, they have Medicare, there still are differences in who gets treatment and the types of, who gets treatment and the type of treatment, the degree of kind of diagnostic testing that's done, we still see those disparities, and it's unclear kind of what's driving those things.
Well, and then you also just made an important point about when you say disparity in what? I mean, a minute ago you were talking about disparities in outcome, mortality, but in this last statement you were talking about disparities in services.
Right.
And so, well, now the question becomes, if it's disparities in services and you're controlling for everything else, what's driving that? I mean, is this racism? Is this what is driving the disparities?
I think we don't
know.
Yeah, I think we don't know the answer to that question.
Okay.
I think that some of it could be racism, and racism, functions in multiple ways. Racism can function in terms of residential segregation. So in the sense that certain types of hospitals, well, for example, let me step back. We know that high volume hospitals, say for cardiac care, where lots of patients come in and get a particular cardiac surgery, patients that go to those hospitals tend to do well.
Right.
So we don't know whether or not it's that blacks tend to receive services in certain hospitals in certain areas where they're, say, low volume. So that's why they're getting lower quality care. So we don't know whether or not it's a system level factor where it is kind of overt racism and people just aren't getting good care, or whether or not it's a relationship too with geography and where they're receiving their care and the characteristics of their environments. And that's the piece that I was talking about before about resources, and resources function in multiple ways. Personal resources, but then also the resources of your environment.
Are we seeing, and I want to move on to Latino in a minute, but I did have a question. When you talk about disparities in outcomes like mortality, morbidity, et cetera, and then you talk about disparities in terms of services or processes of care, is there pretty direct relationship in that we're seeing, and we're talking about African American at this point,
Okay.
we are seeing disparities in services and outcomes. Or are we seeing, even controlling for services, are we seeing poor outcomes? Or once you control for differences in services, then the outcomes become equal? Or
it really depends. Actually, it really depends on the health outcome that you're focusing in on. So,
Okay.
if you're looking at something like arthritis and looking at total joint replacement, we know that the rates for total joint replacement between African Americans and whites, there's a significant difference there. So, who's more likely to say get knee replacement surgery versus not? And some of that may be tied to racial, preferences, differences between blacks and whites for surgery or not to have surgery. So there are differences there, but we don't necessarily see differences in outcomes for how well they do once they receive that care. But then there are other instances where we do see differences in outcomes. And it's related to differences in services. So we know in the case of breast cancer, black women tend to come into the doctor with a later stage of cancer at diagnosis.
Okay.
And some of that could be because they aren't receiving kind of adequate care or appropriate screening. And so when they do wind up with cancer, they're coming in and it finally is diagnosed. It's a later stage, which then impacts their final outcomes in terms of prognosis and higher rates of mortality from breast cancer. So it really kind of varies depending on the health outcome, whether or not we just see differences in outcomes or whether or not there's a relationship between the actual services and that difference in services impacting differences in outcomes.
And even within then, we can look at access versus, as you said earlier, health behaviors. So there may or may not be access, and there may or may not be a desire, a perception, a what have you, to go access those services if they are available, and in some cases they're not available.
Right. And one thing that I didn't actually talk about before, specifically in the context of African Americans, about different kind of cultural norms and different cultural experiences, and that's this issue of distrust of the healthcare system. So even if you do have healthcare access, you have an insurance card, that isn't just access. Access means, multiple things. When you go in, you're treated in a caring manner, you're treated with respect, you don't feel like you're kind of treated in a discriminatory fashion or kind of ignored or not listened to by your physician. Those types of things can also limit, quote, access, right? So it's not just about having healthcare insurance as something that will kind of reduce disparities or reduce service inequalities, or saying that if someone has health insurance and they don't go to the doctor, it's because they don't want to. It isn't necessarily a health belief that they don't want to use the doctor. It could be because of prior negative experiences. So it can become a very complex issue.
Right,
which makes it interesting.
Interesting,
right?
and from a practice standpoint, I think, as you said, even though we're not even near the end, but as you said, you cannot go in and make the assumption by the color of somebody's skin that X, Y, and Z is going to happen.
Right.
Which we'll get to the end. Let's contrast that, what we've been talking about with African American, maybe with Latino.
Okay.
Just to sort of see if there's differences. So where do we are with Latino? I'm so confused already.
Oh no! Well, I hope everyone else is.
No, I'm confused, not in a way that you're not articulating it well, but that from a complexity standpoint. And I guess in some ways it's actually comforting to know that it is very complex. But again, so help us understand when we're talking about the Latino population.
Okay.
As you said, though, Latino being, at least from U.S. federal government definition, Latino being an ethnic group,
right,
which encompasses a variety of races.
Right.
Okay.
I think that's true. But for the purposes of what we're going to be talking about today, we're just going to really talk about Latino from the context of not really looking at racial differences within Latinos, but really just focusing in on what does that group mean in terms of culturally,
Got it.
and kind of the things that bind them together as a group, or kind of shared norms and shared values. One of the first things I think that's important to really mention with Latino, the idea of Latinos and Hispanics and these multiple terms, is the fact that there is no universally accepted term, and so Hispanic or Latino, you can use either term. It refers to multiple groups, people that are from the Caribbean countries such as Cuba, Panama, and then also South American countries like Chile, Central American countries like Mexico. So all of those different countries where basically the Spanish colonized and Spanish is spoken, that encompasses what is, quote, Hispanic. That's usually what we mean by Hispanic. And Latino really refers to people that are from Central America and South America, but it's kind of being used to cover all different groups right now.
So the two are not technically not interchangeable, but for practical purposes, you're talking. They're broad enough categories that you're okay. Okay.
Right. Yeah, they are. And again, like you said, they Hispanic, Latino encompasses multiple races, but really it speaks to a culture and kind of shared norms. In terms of the experiences of Latinos in the United States, we know that there have been different kind of migration stories at different points of time in the United States. So prior to 1970, most of the, quote, Latinos or Hispanics that were coming into this country, and again, I should step back and say not all Latinos are immigrants. That's the first thing that I should say.
Right.
I should step back and say that that there are, several Latinos in this country that have multiple generations in this country. Most of those persons are of Mexican descent, and we tend to see them in southwestern states like Texas, and then also in parts of California. But again, talking about the, quote, experience of immigrants, of Latino immigrants, prior to 1970, most of the Latinos that we saw coming into this country were coming from Cuba. And then as we move forward in time, kind of throughout the late 70s, moving towards the 80s, we saw more people coming from Central America, coming from Mexico, and now and from some parts of South America. And now we see the majority of persons that are coming that are of Latino descent are coming primarily from Mexico, Guatemala, El Salvador, those countries.
Okay.
So it's kind of interesting. And the other thing that should be mentioned in terms of the Latino migrant experience is that there's this, quote, idea of the healthy migrant effect. So to the extent that when you acculturate, the more acculturated you become less healthy. So the more acculturated you become to U.S. society,
the less healthy you are.
The less healthy you become. Kind of. So a lot of times these people are coming here from more rural areas where maybe there was more walking, more physical activity. They ate more raw foods, more fruits and vegetables, and then as you become, quote, more Americanized, and this is not only the case for Latinos but in other population groups, it's the healthy migrant effect for all immigrant communities. The more acculturated you become to American society, eating processed foods, driving, not walking, it impacts your health.
Which then impacts our health system as well. That's a whole other discussion, but that is very interesting. So you use the word, when you talk about Latinos, you use the word acculturation, and you talked about immigrants. So to what degree are the disparities that we see among or with the Latino population driven by degree of acculturation or duration of stay in the U.S.? I mean, are we talking about people who've just gotten here, or controlling for that? Do we still see differences between Latinos and the majority population? Yeah.
Well, we do see differences. There are kind of general differences, just like we see for African Americans, that Latinos tend to have poorer outcomes than whites in multiple areas, such as cancer. The rates of cancer are higher for Latinos in certain types of cancer, say cervical cancer, and then also for diabetes. There are higher rates of obesity and higher rates of diabetes in the Latino population compared to whites. And then there also is this issue of length of stay in the country. And, if you're first generation versus second generation, are you more acculturated? And again, the more acculturated you are, the longer the length of time you're in this country, you do tend to have worse health outcomes. So if we look at the experiences of Puerto Ricans who have been in this country for a long time, are actually a U.S. Territory, they have health outcomes that are very much similar to blacks. In comparison to, say, other Latino subpopulations.
What about comparison to whites, though.
Yeah, in the sense I've said, similar to blacks in that they have poor health outcomes compared to whites. So they're like as bad off as blacks, essentially is what I'm saying, because they kind of have similar experiences in this country tied to racial discrimination and how discrimination may impact your health in terms of internalizing racism, how that has impacts on your cardiac healthcare system, on your cardiac system, hypertension, all of those things can be impacted by perceived discrimination. And yeah, Puerto Ricans are more similar to blacks than whites, say, than other population groups that come here. And certain Latino population groups, say, that come from Argentina or Chile, a lot of them are more well-educated. They're often perceived as white. They're higher SES. Those population groups under Latino tend to mirror that of whites. So really, it's unclear whether or not it's ethnicity or income.
Yes, because you also said that from if I understood this correctly, you said from a general immigrant, if you group immigrants together, that the healthy immigrant or the unhealthy immigrant phenomenon, that folks from Argentina just coming here from a trajectory standpoint, my guess is are headed towards poor health as a function of being in our country, but then it's unclear if that's due to health behaviors such as eating, exercise, etc., or an intersection between that and access and the care that they get?
I think it could be both things. I think it could be the healthcare access and their experiences in the healthcare system that could impact health outcomes, and it also could be a function of acculturation and kind of becoming more Americanized. And it's an interesting trade-off because the longer someone's in the U.S., the more healthcare experience hopefully they will have, and so maybe they may become better at navigating the healthcare system, which might reduce certain types of disparities that they might experience. So really, I mean, I guess the thing about health disparities and looking at different population groups is that it is a complex topic and a complex issue, and there isn't kind of one straight shot that explains these multiple experiences. But definitely, length of time in this country will impact your health outcomes.
Have they looked at that among, and I want to move on to Asian Americans, but if they look, you said immigrants across the board, so white immigrants, African American or black immigrants, I mean, there's an immigrant factor, so this is not just a race factor. So again, same thing, if you come here, if you're Caucasian and you come here from Norway, you're still on average more likely to see a decline in your health the longer you stay?
Yes.
Oh, interesting.
Yeah.
Very interesting.
Yeah, that's very much the case. And it's interesting because acculturation, happens in multiple ways. It could be getting adjusted to the differences in physical environment, differences in cultural environment, differences in food, and you're eating different types of food. There also could be social stress that comes with being an immigrant and not being kind of really fully integrated into society, and the emotional stress, people call it acculturative stress, that comes with being an immigrant, and all of those things could work to impact your health also. As
we move over to Asian Americans, I was going to ask this with Latino, but maybe we can do within the context, to what role does language, to what degree is language a barrier as you're talking about these disparities, or how strong of a predictor is language in terms of these? But maybe you can get at that when you're talking about Asian American.
Okay, sure. In terms of language, I'll just address that briefly for Latinos, that language is a major issue in terms of healthcare experiences. And in a survey that was done by the Commonwealth Fund, kind of looking at healthcare quality for adults who had used health services in the last 2 years, Latinos had very high rates of communication problems. And those communication problems could be whether or not you felt the doctor answered you, whether or not you had a question and you didn't ask it, whether or not you felt the doctor was listening to you, whether or not you felt understood, a range of different types of communication problems. And Latinos had some of the highest rates for having communication problems. And we also saw similar findings for Asian Americans too. And again, some of this may vary by the population group in length of time in this country. So if you speak better English, maybe you have fewer communication problems. And communication could also not just be language, it could also be a cultural thing too, kind of thinking about in the Asian context that there are different cultural norms with different population groups. So for Asians, there is a strong value around showing respect for authority, taking care of family, having emotional control, being humble, and those types of things could really impact the type of communication that you have with your physician.
So what kinds of disparities, you talked about within African Americans, Latinos, diabetes, hypertension, what do we see within the Asian American population?
Okay, Asian Americans, it's very interesting as a population group. They tend to have higher rates of smoking, and there also are higher rates of cancer. And some of the cancer rates are higher in particular subpopulations, such as the Vietnamese and the Hmong. Another interesting thing with the Asian population in this country is, again, that there are different subgroups that have very different experiences and different migration stories. So Chinese and Japanese, for example, and Koreans for that matter, many of them have multiple generations in this country, and the ones that did come to this country, they were, say, coming for economic advancement or for educational advancement, as opposed to other Asian populations like the Hmong or the Vietnamese or Laotians, who really came as a result seeking refuge. They're refugees from persecution and from war, and they had different experiences for coming here. So we have these very different migration stories and experiences in this country within the Asian American context, and those different things overlay with income differences and socioeconomic differences. So we know that people that tend to be better educated and have higher income are less likely to smoke. So we see that the rates of smoking are higher among kind of the lower SES Asian subpopulations, like Vietnamese, Laotians, and the Hmong, in comparison to, say, Chinese Americans.
Okay, but going back to that controlling for statement, with Asian Americans, if you control for differences in SES, etc., do you still see disparities in health outcomes relative to the majority population? Relative to whites.
You see some differences. By and large, Asian Americans have similar leading causes of death as whites.
Okay.
And there aren't as large differences in disparities. There are certain things that tend to be more prevalent in Asian Americans, such as problems with osteoporosis, and we also are seeing increasing rates of obesity, which are leading to increasing rates of diabetes in that population. But by and large, their rates of disease are very similar to whites, and it's only in particular types of health outcomes where we see differences, where their rates may be higher than whites.
Until you start drilling down. Right. So when you start drilling down, though, about, SES, country of origin, etc., that's where the differences start playing out.
Right.
It's more stronger.
Right. And then depending on the type of health outcome that you're looking at, say, if you're looking at a health behavior like smoking, like I was saying, the rates of smoking by and large tend to be higher in Asian Americans, regardless of income, than whites. And a lot of that is tied to kind of different cultural norms around smoking, and it just being more prevalent in Asian communities and in Asia.
Do you see something like, let's play on smoking just for a little bit, duration, I mean, you use the word acculturation, which is not synonymous necessarily with duration of residence here in the United States, but when you take something like smoking, which has got so much attention in the U.S., within the Asian American population, is it to what degree does, again, duration of residence play into that? Whether if you came yourself, or if it's your grandparents who came, or your great-great-grandparents, etc., how does that interact?
Duration of stay with
the smoking behavior. So again, is this a function of people who have only been here for a relatively short time, maybe one generation, or does the smoking behavior sort of stay
and continue?
And continue.
Is it something that's kind of a cultural artifact where it maintains regardless?
Yes.
That's an interesting question. I think that from my reading, what I know about the Asian American population is that people who are kind of newer immigrants are more likely to be smokers than, say, people who have been here longer. So certainly there is a duration effect, but I do think that there is kind of this cultural artifact around smoking, and that being something that's kind of communal and that is just done. Much like in Middle Eastern communities, how they smoke a hookah.
Right.
There's some things that are just kind of culturally bound things that people do that continue regardless of SES, much like eating certain foods. In the African American context, you may eat highly fat foods or high carb foods, even though you're very well educated and know better. But it's kind of a very strong cultural norm around food and eating for celebration, just as an example. So yeah.
Boy.
Which is shared by many population groups, I'm sure. But
yeah, well, and the obesity you said, and if I remember, if you take obesity rates across the different racial groups, African American highest is
actually obesity is highest in Latinos.
Latinos, okay.
Yeah.
And then African
Americans, right, and then whites, and then Asians.
Okay.
Right.
Okay, interesting. Are there specific problems or challenges within the Asian American community in terms of disparities, not on outcome per se? You talked about certain rates of cancer, et cetera, and maybe you can address this for all, but particular types of services or access to particular types of services, is there something that we see when we're looking at Asian Americans as a population that kind of stands out from other types of services?
Well,
whether it's anything, from preventive screening to mental health. I mean, I don't know what it is, but
you actually mentioned the two that I was going to mention. One is the preventive health and Asian American women being less likely to get their cervical cancer screening, to get their Pap test compared to whites, and then also for Asian Americans being less likely to pursue mental health services when they're experiencing emotional distress. And that's something actually that isn't solely unique to Asian Americans. It also is quite common in the African American context, that there is a lot of stigma around seeking mental health services, and also the idea of using alternative medicine to deal with different health issues that they may have. That's common in African Americans and also Asian Americans. So alternative medicine could include things as simple as deciding to seek counseling from your pastor or from a spiritual counselor, as opposed to kind of medicalizing your mental health problem and going and talking to a psychologist or a psychiatrist. Or or it could be alternative medicine could also be diet types of things where you deal with eating garlic or doing different things to deal with arthritis, say in the example of African Americans, or hypertension. They may eat different types of foods to try and control their hypertension and not take traditional Western medicine. So, but in terms of Asian Americans, the two primary things that stick out to me are Asian American women being less likely to seek cervical cancer screening, and then also less likely to be screened for and also to use mental health services when they're experiencing emotional distress. Okay, right at that point, since we've been covering so many different things, can you make the same statement based on your understanding for Latinos? In terms of what stands out, just because we've been covering a lot of it, we're not summarizing, but this is a good chance to summarize in terms of, so for Latinos, what types of services tend to, or is where you see the disparities? I think one of the major disparities for Latinos is certainly around getting screenings for diabetes and also for hypertension and controlling their hypertension and having better glucose control with diabetes. And we also see for kind of different types of public health problems like domestic violence. Domestic violence rates are somewhat high in the Latino population, and women not seeking services related to those issues. The mental health kind of endpoints and consequences of domestic violence, and also kind of impact on the family system. There's some real gaps in use of services there.
African Americans.
And for African Americans.
And all this is relative. I know we haven't broke down all the comparisons, but this is relative to the majority population.
Right.
Okay, got it.
Right. And it's relative to the majority population, but then also just kind of my thoughts on what are the specific cultural contexts for each one of these groups that make these problems particularly unique. And for African Americans, I think HIV/AIDS is a major problem for the African American community, and getting screening, and also talking about sexual risk behavior, and then also mental health services, which I'm very passionate about, and I do research in, and trying to reduce stigma around seeking mental health services, for dealing with things like racism and perceived discrimination, and really trying to reduce the effects of those types of mental stressors so that we can reduce the impact they have on other types of health outcomes, and also improving how you interact in the healthcare system, because we also know that there are comorbidities between psychological distress and untreated things like depression and anxiety. There's a relationship between those things and chronic illnesses like diabetes, arthritis, things with chronic pain. And so when you have untreated mental health disorders, and this is for Asian Americans and blacks, some of the disparities that we see could actually wind up being exacerbated because people aren't able to coordinate care or to really manage those chronic illnesses.
Which is a problem across
all groups, but in terms of disparities, it could widen the disparities.
Okay, so there's a question down here we had, that I'm going to ask, just because I was looking over all my questions and I didn't see this one. Are sex and gender synonymous terms?
Sex and gender are not synonymous terms. Sex refers to the biological, so it refers to maybe physical appearance and biological differences, where we grow our hair, the sound of our voices, the pitch of our voices, those types of things, chromosomes. It really refers to the biologic, whereas gender refers to the social experience of a particular sex, and really refers to the social resources and the stratification that may happen for different gender groups.
Can you give me an example?
Okay.
Talk me through
Sure.
Because what I'm hearing, and we will not belabor this, but I think it's interesting from, again, this what definitions do we use? Sort of what you described. I mean, you described it differently, but at the same time, I'm thinking, well, okay, practically, how is that any different, or are there misperceptions and misconceptions that we can make by equating sex and gender?
Well, I guess really what I was trying to get at is the fact that sex is physical.
Okay.
And gender really is social. So gender really refers to things like what are the expected norms with being female, what are the expected norms with being male, and how you're expected to act. If you are a woman, to carry yourself in a certain way, or if you're male, to carry yourself in a certain way, to act in a certain way, those types of things. So it's more social, and also gender refers to the types of resources and things that may be available to you and how you're perceived. So we know that educational attainment is different between men and women. Men are more likely to achieve a bachelor's degree than women, and kind of what are the social implications. So gender really gets at the intersection of sex with those other socioeconomic things that I was talking about with race, like income, education, access to a variety of services and resources, and how they tend to be more concentrated in one group versus another.
So, I mean, we've heard of differences or health disparities between men and women. But maybe just so we can round it all out, you touch on sort of the highlight within the context of the way we've been talking about Asian American, African American, Latino, men versus women in terms of the big health disparities. And I know most of us know a lot of these, but let's just put it into context. Okay.
So in terms of just kind of overall health disparities, or overall leading causes of death and health issues, women have high rates of heart disease and cancer, and the same is true for men. The one difference that you'll see in terms of leading causes of death is that unintentional injuries and suicide are on the list for men, and and they're not as high on the list or even make the list for leading causes of death for women. And so and again, that could be tied to this idea of differences in our expectations of men and women. So men may be more risky in their behaviors, they may be more likely to kind of be victims of homicide or be engaged in violence than women, and so then there are different types of leading causes of death for men versus women.
When we go back to racial groups, and we talked about the differences between the majority population, that's controlling for gender. So when you look at, when you talk about, differences between African Americans and whites in a variety of the health outcomes, now you've got, to add the complexity, now you've got men and women. But when you look at those differences and you say there are disparities, is that controlling for above and beyond the role that gender or sex plays in that?
Usually people are controlling for gender.
Okay.
Usually people are controlling for gender. And certainly there are certain diseases that are gender specific. So
Right.
things like prostate cancer, we know the rates are higher for African American men than they are for white men. Like I was talking about with breast cancer, black women are more likely to have a later stage of diagnosis than white women. And then in terms of, if we look at leading causes of death, kind of stepping back and looking at gender, men versus women, in different age strata, different things pop out as more important or kind of as bigger issues. So in the African American context, homicide is a leading cause of death. It's like in the top 5 for black males in all age groups up to, I think, age 54. Compared to whites. So it's interesting, and that's kind of, I think, the interesting thing about talking about health disparities and trying to think about definitions, describing disparities, but also to step back and look at pathways, is looking at the intersection between these different things. So it's not just a race question that we see, race differences in homicide or in prostate cancer. It's kind of, what is it about kind of the interaction of race and gender that may make sense, or what is it about black men compared to white men that makes them at higher risk for prostate cancer? Is there something that's socioeconomic that's going on there? Is it an issue of screening? So it's kind of multiple factors, this idea of multiple identities that impact different population groups. And I think we tend to focus in on race primarily just because this is the United States, and that is a physical characteristic, and that's something that kind of is a big factor that in terms of how we define ourselves with respect to diversity.
Right, but as you've highlighted for the last almost 90 minutes, is that it is far more complicated than that. But then, so then my next question is, all right, if I'm a policymaker, you talk about complexity and trying to put into place policy or change policy or affect policy. How does one go about that? What role does policy play in this incredibly complex scenario that you just described?
Policy is very interesting. It plays a very important role, and I think one issue that's very interesting in thinking about the policy perspective is the fact that policy is really impacted by the population group, and who are the large numbers in your population, who are the persons in power in the population, and they kind of set the tone for what gets on the political agenda. And so kind of stepping back to gender again and looking at the different distribution of men and women in this country. If you look at sex ratios in the early 1900s, for every man, say men compared to women, the sex ratios were much higher. There were more men than women. And then kind of throughout the 60s and 70s, those numbers went down largely because of war. And now they're moving back up again. And so we're seeing kind of more even numbers between men and women. And so certainly that's going to impact policy. And also the number of women that are in, say, government, and the number of men that are in government. And all of those things play a piece in who sets the tone for what is policy. The other thing outside of kind of population distribution that impacts policy is societal values, right? And so if we talk about societal values in the policy process, societal values really impact how we perceive problems and what a problem is. So if we think about in terms of the American core values are things like equality of opportunity, freedom, liberty, privacy, a primacy or importance of nuclear family. Those are all core American values, and so a lot of the policies that we develop are going to be in line with those types of societal values. And the other thing that we know is that societal values are not neutral. Values tend to reflect the persons that are in power in your society, and so that's going to impact what types of public health problems are even addressed, and it's also going to impact the types of policies that get developed.
So, I mean, how do we've got this very complex diversity and disparity issue, and what you've just described is a highly complex role for the process of policy.
Okay.
I mean, what efforts are being made? That's one question. Maybe another one, as a public health community of professionals, what should we be doing to affect the changes that you've described, to affect the disparities that you've described in the various studies? I mean, how do we have an impact as a public health community?
Well, I think as a public health community, one of the first things that we can think about is trying to increase the knowledge that public health professionals have on the policy process, and then also thinking about how we can empower different population groups to get their ideas and their issues on the policy kind of agenda. So that's one thing. The other issue is kind of changing how we think about health and really trying to get policymakers to take more of a public health approach. So that means kind of thinking about, again, this idea of an ecologic model of health, the fact that the health of an individual is impacted by their environment, it's impacted by their business, their employers, it's impacted by the media, public health professionals impact the health of an individual. All of these multiple factors can work together to impact the health experiences for persons in our large, U.S. Population, and also dealing with health disparities. So I think that's one issue, is really trying to get policymakers to move from kind of focusing in on, say, just market-based solutions to problems. So outside of health disparities, just say in general health care, we know there's an issue around increasing the numbers of persons with health insurance.
Right.
And our market solution is just, well, let the insurance companies figure it out and let them compete for people based on quality.
Okay.
And that isn't the best way to increase, well, in my opinion, the best way to increase health insurance. Using a market-based model, we need to think about something that's more broad and not just depend on employer-sponsored health care, for example. So in the case of health disparities,
yes,
thinking more kind of broadly outside of the box of just research and, trying to get more data on racial minorities and on different gender populations and health outcomes, but think about interventions more broadly, like employment, and trying to increase educational access for different population groups, or trying to use different types of, multiple sectors in society, using the faith-based community, using different cultural groups, like in the case of Indians, Southeast Asians in this country that have very large cultural groups all over the Southeast, all over the West Coast, or in the case of African Americans, sororities and fraternities, kind of tapping into non-governmental organizations that can partner with the public health community to address health disparities. And kind of as we've talked about, we know that health disparities is a very complex issue, and the experiences of these different populations are very complex. And we're better to kind of get innovative solutions than working with the community. So that's a long-winded answer.
Yeah. Well, no, okay, so what I'm about to say, I hope this may sound a little controversial. Is it safe to say, though, that from a policy standpoint, and from the complexity, the way you just described the diversity disparities issue, that we're not in a place to make policy to address these disparities in a very specific way? Or am I wrong on that? I mean, I guess the way you've just described the complexity of the disparities, it sounds like, how do we address them adequately, or can we address them adequately from some sort of health policy put in place, or is it not going to come from that? Is the disparities the solution to the disparities going to come from practice, empowerment, engagement, etc., and more so than we should put X law and Y law into place, or am I wrong? Are we at that point yet?
Yeah, I don't think it's a matter of right or wrong. I think you raise an interesting point that we really have to work at it from both sides. So I think it's going to take policy solutions, and I mean we do have current things on the books like civil rights legislation that's saying we shouldn't have discrimination, and that's in all facets of life. So if we find out that these differences in healthcare treatment are really as a result of discrimination, which I'm not sure they are, but let's just say, for example, then we have laws on the books to deal with that. But we also could think about other types of innovative policies, say, I didn't get a chance to talk about, but kind of briefly, with differences in life expectancy. So we know that African Americans have one of the shortest life expectancies, and in particular African American males in comparison to white women who have the longest life expectancy. But policies like Medicare, which kick in at age 65, is that something that's equitable for all population groups? Because if the black men are dying at 66, they've put all of this money working in the system for Medicare, but then they don't get any of the benefit, and say maybe they're working in low-wage jobs or in jobs that have limited health care access, so they have bad health outcomes. Is that a fair health policy to have Medicare set at age 65? And so kind of really getting us to push the envelope and thinking about different types of value statements and ways of looking at current policy, I think is the first thing, and look at other ways that we can improve current policy, and are there other types of new policies that we could develop. For example, we know in the context of African Americans and Latinos, they tend to get their health care from, in large number, from minority physicians, and so there are, big economic costs for minority physicians for seeing a lot of charity cases and seeing a lot of uninsured patients, but there's no tax remedy for them for, kind of taking care of those patient populations. So maybe developing some policies that provide some tax benefits for physicians that treat underserved populations. That's a new type of policy, which would be different from changing Medicare cutoffs. But outside of policy, I also think it works on the other side in terms of public health professionals really empowering communities as well, and working with different organizations to kind of challenge the healthcare system, and also empower different communities to make change, and also have community engagement like you were talking about to really make changes in health disparities and reducing them.
Do we have a...
We do have an email.
Okay.
This question to you, Dr. Gary. I had the pleasure of attending a session at which Dr. Glenna Barnes was presenting research into the disparities in infant mortality rates. During that session, she mentioned that African American women who migrate into the U.S. have infant mortality rates similar to those of Caucasian women or European American women. I was wondering if this was a statistic that you were aware of, or if there has been any substantiating research, and what may be the plausible explanation behind this statistic.
That is something actually that I have heard about. Thank you for the question. And it gets to this idea of the healthy migrant. So
right.
It's African American women, or usually people of African descent, that are new to this country. They generally are coming in at a healthier status. So if they're having children, they're going to be less likely to have infant mortality rates that are similar to traditional African Americans. They're going to be more similar to whites because the mothers themselves are healthier. So the infant mortality rates are going to be better and be more similar to whites, which is interesting. And so some of these women that are coming in, the other interesting piece is depending on which countries they're coming in from. If they're coming, say, from Nigeria or Ghana, many African immigrants that are coming here are already educated, and so they're higher SES, even though they're immigrants, kind of in the same case of Latinos that come here, say, from Argentina or Chile, that, come here with resources, with money. Also, like Filipinos that come here, Filipinos that come here that are maybe Chinese ethnicity. They come with more resources, and they tend to have better health outcomes than and be more similar to whites. So it's very interesting that I had heard that.
That is an interesting. Okay, so we're winding down, and my brain is just spinning.
Okay.
Again, on the one hand, you can sort of think about it as confusion. But really, it's the complexity part, and it's, as you said, you made a really important point in the very beginning, which is, the studies say what they say, and we have to take that into consideration. But that when you drill down to the public health professional who is working with a community, what are they to do? What are they to make of this? What are some just sort of take-home practical kind of messages for those of us in the public health community when we listen to this today? What do we make of it? What do we take home? How should it change what we do or how we think? Because it is obviously complex, but we want to walk away with something that we can sort of hold on to in addition to this is a very complex issue.
Okay. That was going to be my first thing. I think that one of the big messages is just trying to get people to realize that health disparities is something that's complex. And also, I think by acknowledging that it's a complex issue gets us away from kind of falling into the easy trap of playing the blame game. And so we're seeing these differences because there's something that's uniquely wrong with or not correct about these groups. And that's something that we want to move away from.
Okay.
And so I think that's part of understanding the complexity and really acknowledging that complexity will be beneficial as a take-home message. The other thing is kind of I would challenge public health professionals in their work environments if they're working, in direct services with communities or if they're doing work trying to develop policy, is to really challenge standard operating procedures, challenge the way things are worded, challenge, the equity of different policies or different situations in your workplace, like I was talking about with Medicare, and really try to step back and think, okay, is this something, this is based on a particular norm that maybe is, very specific to the Caucasian context. Would this make sense for, say, if it's a policy around family leave or family health care? If it isn't a nuclear family, say it's a family that has multiple generations living in one household, think outside of just your own box and how you think, to think about other population groups and how different policies could impact those groups. And also, I think, be more open to talking about differences within your workplace and sharing your experiences and how you kind of see the world, because I think it leads to, in public health, we have this idea of herd immunity. You become, if one person's immune to something, you kind of can pick that immunity up. And I like to think about, herd cultural competency or herd kind of cultural diversity, where to the extent we share more and talk about our experiences, we're better able to understand different worldviews and think innovatively about healthcare experiences, the role of public health, the types of policies that need to be developed. It frees you up from sticking to just one paradigm, which is the paradigm that which is your culture, but really being open to other cultures.
I was going to say, so we sort of want to go the opposite of what we tend to do, which is we tend to make assumptions based on any of it, race, ethnicity, SES, gender, etc. But this really is a matter of trying to put those aside for the individual interaction and find out, does it meet what we know from the big population studies, or does it go against that? Wow. Okay.
And the other thing, too, I was just thinking about other kind of take-home messages. I think some quick take-home messages, too, would be for public health professionals is to encourage legislatures to develop policies that really encourage the collection of racial and ethnic data by different health insurance companies so that we can monitor what's going on at the state level, in different states and in different health insurance companies. Some collect that data, some don't. So that'd be one area of policy change that I would encourage. And then also for public health professionals, if there isn't something already in place in your workplace around cultural diversity and cultural competence, but having that be something that all employees really participate in, not just kind of high-level administrators, but also, kind of at each layer, because it has implications for how employees work together, but also how they interface with the larger community as public health workers.
This is a last question, which may be way too huge for the very end. Cultural competency. Who is or what is a culturally competent person? In a minute or less.
Okay. Thank you for that very hard question.
Or is that impossible?
No, it's not impossible.
Okay.
It's not impossible. I think a culturally competent person is someone that isn't ethnocentric, who doesn't think that their worldview or their culture is the only culture and looks down on other cultures. I think it's someone who's more culturally relative, who really looks at how their culture relates to or compares to other cultures and is open to receiving new information and sharing information about their culture. I think it's someone who is exposed to other ways of thinking, other foods, other types of dress, other types of communicating that are different from their own, but they see those differences, but there isn't a value judgment there. And also that they aren't quick to kind of rely on stereotypes, but they deal with the individual. And I think that's the one tricky thing when we talk about the different cultural contexts and cultural norms, say, of Asian Americans, that, humility is important in emotional control. Well, you may encounter an Asian American who's very boisterous, who, is not, kind of very controlled in their interactions, or, different population groups, there's a respect for authority or a respect for the elderly, or a high focus on the importance of family. But you may encounter someone who rejects all of those things and, wants to be single and not have kids, and, whatever the different examples are. So I think kind of we learn about different cultures, but we don't rely on them in the sense where they then become stereotypes.
Right.
I think that's a culturally competent person.
That was great. That was great, and it's a great note to end on.
Okay.
Because I think that Lisa's last statement is probably one of the most important, which is this is a complicated issue. It is difficult, which tells us that there are no blanket statements, but at the same time, we can strive to become more culturally competent, as you just defined, which is a great thing for us to take home, to take back to where we practice, where we work, and as always, with all these broadcasts, to keep in the back of our mind. We are done, but I don't want you to go yet because we've got all kinds of things coming up. In fact, Friday, I'm going to be back here talking with Dr. C.J. Davis, who's going to be talking about continued psychological difficulties of first responders and the affected general population 2 years post-Katrina. And then on January 17th, I'm going to be back again, and I'm going to be talking to you about fitness for duty and how to create a system for making health-related behavior change. And then on January 31st, we'll be back talking about an emergency management assistance compact. All the program information for the programs I just described are up on the department's website, as well as registration information. Let me also remind you, please go back online to complete the program evaluation. Thank you for watching, and until Friday, have a good afternoon.